Welcome to the fascinating and confusing topic of central auditory processing disorders. I'm Gail Richard, and my objective in this seminar is to provide an overview of central auditory processing disorders, differentiate them from language disorders, and briefly discuss the role of both audiology and speech-language pathology in addressing them. I'm currently employed part-time at Eastern Illinois University in the Department of Communication Disorders and Sciences. I want to disclose that ASHA provided an honorarium to me for preparing this seminar. I also have several publications, including both assessment tools and clinical materials in the area of processing disorders, for which I receive royalties. Those are with ProEd, Dynamic Resources, and MedBridge. My non-financial disclosure is that I have the privilege of currently serving on the ASHA Board of Directors as the immediate past president. We're going to begin our discussion on central auditory processing by looking back to some of the first uses of the terminology. Dr. Michaelbust was among the first to introduce the term auditory processing in his 1954 textbook on auditory disorders in children. His use of the term was very broad and was explained as having intact peripheral hearing, but a deficit in the ability to listen and respond meaningfully to an acoustic stimulus. Vygotsky talked about processing as being a complex skill, relying on integration between the auditory stimulus and linguistic knowledge. Again, very broad and encompassing. The relationship of auditory processing and language was also continually debated, as referenced here in the seminal article by Dr. Norma Reese. In the late 1970s, audiology carved out very specifically central auditory processing, as it related to the ability to peripherally receive an auditory stimulus, but then experience difficulty transferring it through the central auditory nervous system to the upper cortex, where linguistic interpretation of that auditory signal could occur. The term central auditory processing continued to be used in a variety of ways for several decades, but it was defined by various researchers and authors in different ways. In 2005, ASHA convened a working group of audiologists to address the issue and the confusion regarding the term central auditory processing disorders. The task force defined the term, delineated the specific skills that were encompassed within that disorder area, and then generated a technical report that recommended the diagnostic criteria. But they also put central in parentheses, which took us back to the term auditory processing rather than central auditory processing. So this was an indication that central auditory processing and auditory processing are synonymous terms. While audiologists were designated as the primary professional for diagnosing CAPD, speech-language pathologists were the professionals usually responsible for addressing intervention for the disorder. So in 2007, ASHA convened a task force of both audiologists and speech-language pathologists to address the role of the speech-language pathologist in auditory processing disorders. I had the privilege of chairing that task force, and it was a challenge. The committee members couldn't reach agreement. So, in 2011, each of the committee members were invited to present their perspective in a clinical forum that was published in Language, Speech, and Hearing Services in the schools. That series of articles is really an interesting and enlightening read, and I really recommend it to you. While audiologists are responsible for assessing the audiological skill set that's associated with auditory processing disorders, the functional impact of auditory processing disorders on language and learning is usually the responsibility of the speech-language pathologist. So both audiologists and speech-language pathologists need to know how to delineate a child's strengths and weaknesses in APD. So this slide details the definition for auditory processing that resulted from the 2005 ASHA working group. As you can see, the definition includes multiple auditory skills that are encompassed within the purview of auditory processing, such as sound localization, auditory discrimination, pattern recognition, temporal integration and segmentation, competing signals, and degraded stimuli. The 2005 working group also tried to address the controversy or overlap with the linguistic aspects. The technical report listed skills such as phonological awareness, auditory memory, auditory attention, auditory synthesis, comprehension, and interpretation as being higher order cognitive communication or language functions, and therefore should not be included in the definition of auditory processing disorders. However, there continues to be debate as to how you separate or delineate auditory processing from phonological or language processing. For example, a child who has difficulty in auditory discrimination of sounds. Is that an auditory discrimination problem under the definition and diagnosis of an auditory processing disorder? Or is it a phonological awareness problem that should be diagnosed as a language deficit? This presents a significant problem because assessing and treating the multiple aspects of an auditory processing disorder is a challenge. I like to use the analogy of an old Hindu fable that describes 6 blind men who are asked to describe what an elephant is. The person who's at the trunk describes the elephant as being similar to a snake. The person at the tusk says, no, it's like a spear. The person at the ear argues that an elephant is like a fan, while the person at the tail describes the elephant as similar to a rope. The 5th is at the leg and likes the elephant to a tree trunk, while the last one is at the body and describes a wall. The point is, no one looked at the entire elephant. And that's what's going on in auditory processing disorders. Professionals are failing to look at the whole animal. They're seeing one part specific to their orientation to auditory processing, and then labeling the disorder without seeing the big picture or the whole animal of auditory processing. One significant challenge is to achieve a consensus definition for auditory processing disorder. We acknowledge there are multiple auditory skills included in the definition of auditory processing. So, how many skills need to be in deficit to diagnose a disorder? 1, 3, 5? Are some skills more important than others? Most audiologists who assess auditory processing use a battery of tests that evaluate a number of different skills. But each audiologist tends to put together their own battery, just like speech-language pathologists who constitute their own battery of tests to diagnose a language disorder. So when do the results indicate a disorder in auditory processing? The 2005 working group advocated that an individual needs to perform 2 standard deviations below the mean on 2 or more tests used in that processing battery. But that's a recommendation, and it isn't always followed by everyone. There have also been some studies that question the specificity and validity of some of the APD assessment instruments. In other words, what are they really testing, and are the results consistent? An additional issue to consider is the impact that a language deficit could have on test performance for auditory processing. For example, directions on a dichotic test in an auditory processing battery might be the following. You are going to hear a word in your left ear. At the same time, you're going to hear a different word in your right ear. Tell me the first word you hear in your left ear. Now, if I have a language deficit in concept development, same, different, left, right, first, second, I can't comprehend those directions to respond correctly. Consequently, we have some overdiagnosis and erroneous diagnosis of auditory processing disorders due to the influence of language deficits, attention deficit, and global disorders like autism that are going to interfere with accurate test performance. In addition to the challenges in diagnosing auditory processing disorders, we also have to consider what the research suggests regarding intervention. A systematic review conducted by the task force that I chaired is summarized in the Clinical Forum in Language, Speech, and Hearing Services in the Schools, the July 2011 issue that I mentioned previously. The systematic review looked at studies that used a population diagnosed as having an auditory processing disorder to determine treatment gains. The general consensus in auditory processing intervention has been that you can drill the auditory skills in deficit and they will improve. Several of the studies did show improvement in isolated auditory skills that were targeted, such as phonological awareness, as well as observation of improved listening, but there were not realized gains in language or academic performance. In other words, specific drilled skills improved, but there wasn't carryover or generalization to functional improvement in academic or language areas. There are a few challenges and controversies that continue to surround the area of auditory processing. There's consensus on the fact that auditory processing encompasses a variety of auditory skills. But some confusion arises when we try to differentiate phonemic awareness as primarily a component of auditory or language processing. Yet many of the higher cognitive processes involved in interpretation of the auditory signal are acknowledged as being in the realm of linguistic or language processing. While the audiologist is responsible for assessing the acoustic parameters encompassed in auditory processing disorders, the speech-language pathologist is responsible for addressing the deficits when they conduct intervention. Research has shown improvement in isolated, drilled skills, but without the desired generalization for functional improvement in language and academic performance. So that raises a question. What is the primary focus or goal in intervention for auditory processing? Is it improvement in discrete skills or functional improvement in the ability to abstract meaning from the auditory stimulus? I believe the focus in auditory processing should be to ensure that an intact, accurate auditory signal has been received and transferred to the upper cortex. Then we make a switch to language interpretation of that signal, and this begins with phonological awareness skills and linguistic decoding skills. Therefore, adequate processing involves a continuum of skills. We need an intact peripheral auditory system to perceive and receive the acoustic stimulus. This is generally presumed, but it needs to be checked before starting an auditory processing assessment. Then the central auditory nervous system, or the CANS, has to transmit the signal through the brainstem to the upper cortex. As we enter the temporal lobe at Heschel's gyrus, we use phonemic knowledge to discriminate aspects of the acoustic stimulus. This is an obvious overlap area in the continuum, where both audiology and speech-language pathology share responsibilities, and so it contributes to some of the confusion in diagnosis. The next step is to move beyond sound discrimination to interpretation, to abstract the message from the signal using language knowledge. Finally, executive function skills are used to organize and execute the response, which can be written, verbal, or behavioral. While certainly not a clean linear progression, as Vygotsky hypothesized years ago, this is a continual back and forth process, but we do need to chunk or isolate the main neurological structures that are involved in processing so we can focus intervention and effectively address the presenting level of breakdown or difficulty. So I advocate that we think about processing in three main chunks: acoustic, phonemic, and linguistic. The first three areas in this continuum on the slide are auditory processing. The last three areas are language processing, with phonemic processing being the overlap. So phonemic processing is the end of auditory processing and the beginning of language processing. This is a visual graphic representation of the continuum. The peripheral auditory system, the central auditory nervous system, and into the upper cortex are the responsibility of the audiologist to assess. However, the transition area marked on the diagram is at the upper cortex temporal lobe and overlaps with the assessment areas of the speech-language pathologist. When we begin to discriminate characteristics of the acoustic signal, both audiology and speech-language pathology are involved. Audiology will tend to focus more on the non-meaningful discrimination, such as timing. Was it a long or a short signal? Patterns, high or low tone. Auditory segmentation, how many sounds were there? And competing signals that are evaluated in dichotic test, two different signals presented to each ear simultaneously. The speech-language pathologist tends to focus more on phonemic discrimination. Was it a B or a P? What word did you hear? Did the words rhyme? Then we move into language knowledge to attach meaning or get a picture in the brain. That's our ability to comprehend the message that's encoded in this signal. So let me do a quick illustration of the continuum for auditory processing. I want you to listen carefully. Ga, coma. Did you hear it? Then your peripheral system picked it up. Can you repeat it? If yes, then your central auditory nervous system transferred it to the upper cortex. Can you tell me the first sound you heard? If you say ga, then you just demonstrated auditory discrimination by segmenting off the first sound. Now, you have just demonstrated several auditory processing skills. Can you tell me what it means and respond? Probably not, unless you know this Nigerian language. So the linguistic code or language is where you stopped on the continuum. That's also where auditory processing stops. I want to briefly walk through the entire continuum of processing, including the language aspects, and highlighting the types of skills and modifications that might be implemented if the deficits or breakdowns occur at a specific area in that continuum. The acoustic skills are the purview of audiological assessment, and deficits would be diagnosed as an auditory processing disorder. There's a variety of specific auditory skills that can be evaluated in an auditory processing battery of tests. Most will be categorized into three main types: binaural processing, temporal processing, and auditory discrimination. Evaluation tasks can be monaural, one ear, binaural, 2 ears, diotic, 2 ears hearing the same thing, dichotic, 2 ears hearing different things at the same time, as well as electrophysiological. Stimuli can be sounds, numbers, and words, both real and nonsense. If the student has difficulty in the acoustic skills involved in processing, then the specific skills in deficit can be directly targeted. The intervention programs are generally targeting a specific type of acoustic skill. For example, the original fast-forward program manipulated the temporal or timing aspect of the signal. The premise was that the normal rate of speech was too fast for individuals to accurately process. The computer-generated stimuli was slowed down, and it sounded distorted to our ears, but it gradually moved toward normal timing presentation as the child moved through the games. Another example is the auditory integration training program, such as the Tomatis program. They manipulate the frequency aspects of the signal by filtering sounds. There are many auditory processing treatment programs available. However, the speech-language pathologist or the professional implementing the intervention needs to carefully assess what auditory subskill is being targeted in that treatment program. If the individual failed a certain type of auditory test in the processing battery, doing a treatment program that targets a different auditory skill is going to be a waste of time, money, and energy. Modifications can also be implemented to compensate for the acoustic or the auditory processing challenges. If the auditory system is weak or deficit in transferring the signal, then add visual stimuli to support that acoustic stimulus. We don't make a deaf or hard of hearing child listen harder until they hear. The principle is somewhat the same for a child with an auditory processing deficit. Don't try to remediate through the weak system. Certainly provide auditory stimuli, but initially pair it with visual or motor stimuli to supplement the acoustic signal. You also want to evaluate the environment to minimize any distracting or competing auditory stimuli. You can amplify or clarify the acoustic stimulus to improve the chances of it being received and transferred accurately to the upper cortex for linguistic interpretation and comprehension. The primary focus in accommodating an auditory processing deficit is to improve access to and enhance the clarity of the acoustic signal. Discriminating and interpreting the specific characteristics of the auditory signal are part of auditory processing. Loudness, pitch, timing, those are examples of variables that can be manipulated by the audiologist to assess auditory processing. If the discrimination task is specific to the individual phonemes that constitute the linguistic code, then the focus becomes phonological awareness and can also transition into phonetic representation of those sounds with letters. And these serve as the foundation for the acquisition of literacy skills. This becomes an area of overlap for both the audiologist and the speech-language pathologist. The audiologist tends to be more concerned with accurate reception of the phonemic signal, while the speech-language pathologist is more concerned with acquisition and discrimination of the phonetic code to then develop skills for reading, spelling, and written language. The skills listed here are examples of areas to target in auditory processing intervention. These all focus on hearing and manipulating the various phonemes. For example, k, a, t is an example of sound blending to result in the word cat. Sound segmentation would be to separate the word cat into its individual components. K, a, t. An example of closure is where some of the sounds are missing and the individual has to fill them in, kind of like the static on your cell phone. So Andy R would be candy bar. This generation tends to be very visual in their recreation time, with video games that actually penalize you for listening or going slowly. So impulsive auditory processing or tuning out the auditory stimulus is fairly standard. So we want to play sound games that heighten awareness of sound positions and specific phonemes. That's a better strategy. Play a game where you say a word and the child has to say a word that starts with the last sound in the word you said, or has to generate a rhyming word, or needs to identify the vowel sound in the word, or has to identify how many syllables are in the word. These are a much better use of time than tuning that child in on Game Boy. We can make playing sound and word games fun. And while we're doing that, we're working the phonemic skills that are weak in this generation and that are leading to lots of diagnosed reading deficits. Underlying dyslexia is usually sound discrimination deficits in segmenting and analyzing the phonemes in an acoustic signal. Linguistic processing is the ability to comprehend and attach meaning to the auditory signal. Language processing skills provide the basis for higher level, more complex metalinguistic skills. This aspect of the continuum is not part of auditory processing disorders, but certainly part of the continuum of skills that's encompassed within the concept of processing information. This is the purview of the speech-language pathologist to assess and treat. If the child is receiving the signal, repeating the signal, identifying acoustic characteristics of the signal, but it's like a foreign language to them, if they're confused, there's a latency in responding, then the deficit might not be auditory processing, but is actually in language, regardless of what diagnosis they might bring to you. So in this case, amplifying the signal, preferential seating, those aren't going to help. This individual needs to develop a more solid language foundation in semantics, syntax, phonology, morphology, or pragmatics, so they can better comprehend the message that's encoded in the auditory signal. So this slide provides some examples of language skills that could be deficit in a language processing disorder. If the problem is not the acoustic signal, but attaching meaning to the signal, then we use language strategies to compensate for the deficit. We rephrase, we provide examples, demonstrate directions to make sure they're comprehended. If the auditory is the weak channel, then supplement with visual and motor input. That will help clarify and facilitate understanding of the auditory message. Take off time demands, especially to accommodate the latency that we usually see in individuals with processing problems. Encourage that individual to slow down and listen carefully before trying to respond. Teachers, parents, and therapists need to be careful about limiting the length and complexity of the auditory stimulus because that will help facilitate the attachment of meaning. The ability to plan, organize, manage, and execute a response is part of what are called executive function skills, and these are based in the prefrontal frontal cortex. An individual has to be able to coordinate and integrate the language foundation skills from the temporal lobe. An analogy that I use in one of my books is to think about an orchestra. Each individual section of the orchestra can be excellent, but the conductor has to be able to balance and integrate all of those sections together to accomplish a productive, positive output. So executive functions are an aspect of language intervention that sometimes gets overlooked. Specific discrete language skills can be well developed, and the students can perform well on language subtests, but teachers still complain that the individual is struggling in the classroom. And in this case, the last aspect of the processing continuum hasn't been addressed to help the child learn to integrate, plan, make decisions, and formulate productive responses. So example skills in the area of executive functions are listed on this slide. Compensating for executive function deficits usually involves putting structure and routine in place. visual checklists, organizational strategies, breaking down tasks into steps. Those are all examples of strategies to work on weak executive function skills. So, for example, if a student has a paper to write, start by identifying the subject or the title. Then work on finding some resources. Plan an outline of the major topics that are going to be addressed. Then work on writing an introduction, paragraph by topic, and then a conclusion. Making lists. That's another checkoff kind of strategy that can be used to address weak executive functions. Again, this isn't part of auditory processing disorders, but it is the last step in the full continuum of effectively processing information. We began by acknowledging that processing disorders are complex and comprised of multiple different auditory, phonemic, and linguistic skills. As a clinician, it makes sense to me to chunk processing disorders into at least those three major categories: acoustic, phonemic, and linguistic. As a diagnostician, it makes my initial detective work a little bit easier to try and identify the major area of deficit or breakdown. Is the individual having difficulty receiving and transferring an intact signal from the environment to the upper cortex? That is part of the acoustic aspect of auditory processing. Is the individual struggling to discriminate or identify the characteristics of the auditory stimulus? That is an acoustic phonemic problem with overlap in both audiology and speech-language pathology, but it is encompassed within auditory processing disorders. Is the individual having difficulty interpreting or attaching meaning to the signal to then organize and execute a response? That's linguistic and executive functions, and it's not part of auditory processing. It moves into the language realm of speech-language pathology. So an individual can demonstrate deficits in one, two, or all three major aspects on the processing continuum. To plan intervention, the professional needs to identify where the breakdown is occurring along this continuum, and then isolate the specific skill sets that are in deficit to effectively manage the disorder. Treatment goals can address remediation of discrete skills, but they also have to include environmental management strategies. Both audiology and speech-language pathology have a role in auditory processing disorders. However, the diagnosis of auditory processing disorders is the realm of audiology. Acoustic aspects of the signal transference need to be assessed by the audiologist. Phonological linguistic aspects of the signal can be assessed by both the audiologist and the speech-language pathologist, but are usually addressed in intervention by the speech-language pathologist. A differential diagnosis that determines the level and type of breakdown in auditory processing disorders is critical to effective intervention. Without taking time to carefully assess the components or the skills involved in an auditory processing disorder, remediation will lack focus and waste time and energy. So we have come full circle back to where we started with Dr. Michael Bust. We all have a professional responsibility to look at all aspects of the auditory processing elephant, to put the pieces together through careful diagnostic procedures that will then facilitate effective intervention. This presentation is part of the upcoming ASHA Audiology Online Conference on Central Auditory Processing Disorders. The conference will examine the complexity of CAPDs, including how to select evidence-based measures for evaluation, how to interpret results accurately, and presentations of useful and specific recommendations for intervention to achieve functional outcomes. Presenters will include both audiology and speech-language pathology perspectives. as well as other measures that are used by professionals to examine potential related deficiency in psychosocial, educational, and neurocognitive skills of individuals who have suspected central auditory processing disorders. You can learn more at the website that's on this slide, www.asha.org/events/audiology. Thank you for embarking on this journey to explore auditory processing disorders. I hope you found the information stimulating and thought-provoking.